Wow, that was hardcore, Rajiv. Wow. Thank God I don't do children. Thank you. My name is Emmanuel and Mavrikakis, and I am a director of vitreoretina surgeon in Greece. I would like to thank both Rajiv and Roxanne for the kind invitation. So it is thanks to those guys, to those two guys, that now we have evidence that pneumatic retinopexy actually works well with good visual acuities, no metamorphopsia or less metamorphopsia, and less morbidity, less cataract. However, as we all know, because we are all eye surgeons, or the most of us, each procedure, each technique has the risk for some complications. So that's what we're going to be talking about. I have no financial disclosures. Right, so the first one is FISEX. FISEX is usually technique related. As we already described, it is a matter if you have your needle in the middle of the vitreous cavity and you eject the gas bubble, then because of the vitreous, the gas bubble will be divided into small bubbles, creating FISEX. And okay, it's not the end of the world. It will affect your visualization of the retina, and it will make difficult to laser if you haven't done cryo before. But if you place the patient face down, they will coalesce between 12 to 24 hours, and then you can continue with your pneumatic. Number two, subretinal gas. It's unusual, but it can occur because in the setting of FISEX, so small bubbles and large breaks, the small bubble can escape under the retina, and then you have subretinal gas. But again, you can tease it out with the patient in the supine position using scleral depression. And if this is not possible, then you might need to proceed to vitrectomy, where you're going to be actively aspirate the gas bubble under the retina. Number three complication could be anterior chamber gas. That usually occurs in pseudophakic patients with open posterior capsule or zonular dehiscence. It affects the visualization of the retina again, and it makes the laser difficult, but it can actively and slowly be aspirated with the patient sitting in an upright position. Number four, that's very painful for the patient, is the suprachoroidal gas. And in some cases, it can be advantageous if the break is in the position where the subchoroidal gas is, because it acts as a temporary scleral buckle. You don't need to drain it, but you might need to re-inject gas and then continue with your pneumatic. Prehyaloid gas, it usually occurs in young phakic patients with formed vitreous, and it is because the bubble is trapped in the space of Petit. It appears oval and it stays anterior even with the patient in the prone position. But as the gas expands, then it may break into the vitreous cavity within the first 24 hours. Now, this is what I want you to keep in mind, that as Roxanne already said, the success of the pneumatic retinopexy depends on your very meticulous first examination with scleral depression, making sure that these are the breaks that you have, because you don't want to miss any breaks, or you don't want to miss any new breaks. So that's why we need to emphasize the need for close follow-up of the patient and very careful and thorough evaluation. Endophthalmitis, it is very rare. Many authors think that this might be due to the antibiotic properties of the expansile gas, but if it happens, then it can be treated as usual with tap and inject or vitrectomy, depending on the visual acuity and the severity of the endophthalmitis. And finally, PVR, epiretinal membranes and macular holes, these are known complications of the retina detachment, and the risk is likely no greater than with scleral buckle or vitrectomy. I would like to thank you for your attention.
So, I think what's interesting to notice there is, although you do have some potential unique complications that can occur